Okay, so now we're going to talk about things that have to do with the implantation of the placenta, and this is called placenta previa. So if you look right here, you can see hopefully the placenta will attach towards the top or the fundus of the uterus. If it does, then it has a very strong foundation. If it implants down here or covering the cervical opening, we call that a placenta previa. And remember that this lower segment and the cervix soften during pregnancy. So if there is excessive movement, you do a vaginal exam, you can cause the placenta to come away from the uterus and cause massive amounts of bleeding. And this will happen in the third trimester. So let's talk about the symptoms of placenta previa. So the placenta is not being ripped away from the uterus, it's just coming away because of the softness of the uterus down below. It's painless. You'll see bright red bleeding, and it occurs late in the pregnancy. The uterus will be soft. It won't be tender, and it will have a normal tone. And then you might see that the fundal height is greater than expected to gestational age, and this is because of the possibility of the pooling of blood. So how do we care for these kinds of patients? So we're going to monitor their vital signs, their fetal heart rate, and the fetal activity to make sure that the fetus is okay with this bleeding, and make sure that the baby is being perfused efficiently. Like I said earlier, we're going to avoid vaginal exams. If we do a vaginal exam on a placenta previa patient, then we could cause massive amounts of bleeding. And we will know the placenta previa is there when we do the initial ultrasound, because we look for the placenta attachment when we do the ultrasound. So we're going to make sure that they maintain on bed rest, and we're going to monitor the amount of bleeding. And then if the placenta previa is low-lying, marginal, or a complete, then we're going to have to do a C-section, because there is no way for the baby to pass through if the placenta is covering part of the cervical opening. Okay, so I want you to think about placenta previa and kind of compare and contrast it with placental abruption. In both cases, the placenta is coming away from the uterus, and this happens in the third trimester usually. But this is happening because of some sort of traumatic experience. So this is a painful experience versus placental, going back, placenta previa, that is painless. Okay, so we'll talk about some of the other things that make placenta abruption different than placenta previa. So it's that plus premature separation after week 20. And you can watch this placental abruption video if you like. I might upload it. I'll watch it again and see what it looks like. And it's caused by hypertension of the mom, meaning the blood vessels are not able to sustain the placenta. Blunt trauma, cocaine use, cigarette smoking, anytime that these are vasoconstrictors, so vasoconstriction will cause it. Premature rupture of membranes, and if there's more than one baby fetus, that can lead to placental abruption. So this is either dark red bleeding, or if it's a hidden abruption, the blood will just pool inside the placenta and you won't know that she's actually bleeding, because it will be internally. So you'll have sudden onset of uterine pain when the placenta separates. The uterus will become board-like and very rigid. That is a classic sign of placental abruption. And they'll have severe abdominal pain. So remember, this is painful, whereas placenta previa is not painful. You'll have contractions with hypertonicity, so the uterus is hypertonic. And you will see signs of fetal distress because the baby is not being perfused, because the placenta is not attached significantly or enough to the uterine wall. And then, of course, you'll see signs of hypovolemia because of the loss of blood. Oh, excuse me. Okay, so here are different kinds of placental abruption. You can see here, so this is the cervix. Here's where the placenta adheres. You can see that this is a partial or concealed hemorrhage. So there's bleeding going on right here, but there's nothing coming out, so we don't actually know. We have to look at the vital signs to tell. And she'll be experiencing pain. And if she starts being tachycardic, then we know there is suspect of hemorrhage. And sadly, when we do a ultrasound, you can't tell the difference between the placenta blood flow and the abruption blood flow because the ultrasound does not detect that easily. So here is a partial separation, and you can see there is an apparent hemorrhage. Here's a complete separation. So all you have is the placenta is separated, but you see the amniotic sac is still connected, but it's completely concealed. So there will be massive amounts of bleeding right here. The last thing about the placenta is you'll see this in the units. Maybe you've seen it already if you've had your OB rotations. These are, let me move this up a little bit, placental abnormalities. And this is where the placenta attaches too deep, and it's called placental accreta. So a normal placenta should just adhere kind of superficially to that endothelial layer, and that's sufficient enough to create the blood supply between the mom and the baby so that they can transfer gases. With placenta accreta, it actually goes into that myometrial layer, and the problem becomes when the placenta is detaching that it does not detach smoothly. So with accreta you might have an attachment okay, but you have massive amounts of bleeding because of the attachment. With increta, which it penetrates through the uterine wall, and percreta. With percreta, it can go all the way through the uterus and actually start attaching to different organs, say like the bladder. With these two, she is not going to be able to have a regular delivery. It'll be delivered through C-section, and most likely she will have to have a cannot think of the word. Hysterectomy. That's the word. She will most likely have a hysterectomy because there's no way to detach this from that uterus without causing massive amounts of bleeding. So it's really sad when it's a first baby and they have this, and they will probably never have another baby again. Okay, now this is in chapter 9 of your ATI. These are the medical conditions, just different kinds of things that you will see medical problems in pregnancy. And the first is hyperemesis gravidarum. This is massive amounts or persistent and large amounts of nausea and vomiting, and it causes electrolyte imbalance, and it can cause harm to the fetus and to the mom if we don't intervene. And this is not normal nausea and vomiting. This is where she loses an extreme amount of weight. So sometimes she might have an extra higher than normal level of HCG, or it extends longer than that first trimester, and then it can lead to hyperemesis gravidarum. To diagnose it, women's weight is 5% less than pre-pregnancy weight. So she cannot maintain her weight. She's losing weight. So we're going to look for dehydration with possible electrolyte imbalance. So the real serious part about this is the electrolyte imbalance, right? And there is a likely need for hospitalization for some of these patients. So the first med that we should give, and this is the most safe and effective med, is a mixture of pyridoxine, which is vitamin B6, and doxylamine, which is used in sleep aids. And if you combine those two together, it's very safe and very effective. But what do they usually get? Especially if they go in through the ER, they're going to give them Zofran, which is not as safe as this mixture. We're going to also teach them to avoid spicy, greasy, or odoriferous foods, so smelly foods. They're going to eat these small servings of carbs and drink this carbonated liquids to help settle their tummies. And ginger is a good way to help, calm the nausea. So let's go back. I'm not going to go back. So if she is in the hospital, she will most likely be given NS with added electrolytes or a lactated ringer, which is basically NS with electrolytes added to it. All right, so iron deficiency anemia, this is every pregnant woman needs to take iron. If she's experiencing iron deficiency, there's a extreme deficiency. So you'll see things like pale skin, brittle nails, and possible shortness of breath because she lacks that hemoglobin, and she'll see pica. Pica is the desire to eat things that are not food, things like dirt and chalk and things like that. Women who are iron deficient will crave dirt and different things because their body is craving that iron that they need. So iron intake for all women should be 27 milligrams per day. But if they're anemic, we want to give them much more. And this is going to cause constipation. So we're going to first have them take it with orange juice or something citric to increase that absorption and also to avoid dairy products when they're taking iron. And then we're going to encourage also a complete diet rich in vitamin C all around. And then we want them to decrease the constipation problems to increase their fiber and their fluids. Okay, we will finish this presentation with gestational diabetes. So, gestational diabetes is diabetes that normally isn't there. The onset occurs during pregnancy, and this is because the pancreas has some deficiencies in those beta cells, but you don't know about it until there's a stressor like pregnancy that will show the beta cell deficiencies. So most women, after they have gestational diabetes, will return to that euglycemic state. So you get rid of the stress of pregnancy, and then they will go back. And that is really a problem because what happens is these women have gestational diabetes, they have to watch what they eat, exercise, things like that. Then they cut the cord and then their blood sugars are fine. But what they don't teach, and this has to do with the lack of continuity of care between the OB office and their general practitioner, is if they don't get the education that 50% of these women will develop type 2 diabetes within the next 5 years, then they will most likely develop type 2 diabetes. So there has to be lots of education with these women so that they will avoid developing type 2 diabetes. So once a woman has gestational diabetes, she will need to be on a different diet the rest of her life if she wants to avoid getting type 2 diabetes, and then especially if she does get type 2 diabetes.